So if your renin is high, you're dealing with renal artery stenosis. Get a CT angio, which I find to be the best, not as compared to Doppler. We have had patients who came to us with hyperrenism and they were found to have aortoarthritis and RAS, which can cause that. If renin is low, DOC is high, then you're thinking of CAH. You will of course have DSD, you will get the diagnosis there. Otherwise, you can go for rarer causes. If DOC is also low, LDO is high, then you're thinking of a aldosterone producing tumor, hyperplasia, or genetics. LDO is low, so low renin, low LDO, normal DOC. Two major differentials. You have got either apparent mineralocorticoid excess or little. How would spironolactone response tell you? If the spironolactone response is present, it will be
AM.
it will be a apparent mineralocorticoid excess, and if it's not there, you can think of a Little syndrome. Both will respond to amiloride. So amiloride response is not going to help you out from that regards. In more older individuals, particularly let's talk about adults, here you should look at the aldorenin ratio. If it's less than 20, primary is out. More than 20, you can do a saline infusion test. If it's suppressed, again it's ruled out. Not suppressed, somebody who is planning for surgery, you have to start thinking of doing further evaluation. Less than 20 years, you should do a genetic study. If surgery is not being planned, you just give medical management. Otherwise, you do adrenal sampling. Because adrenal sampling is not easy. It's going to be difficult to cannulate that. And even there, you may not be able to find things. So, Dr. Alappan, 10-year-old girl with headache, hypertension, creatinine is normal, echo is normal, there is hypokalemia. What do you think?
You have to look for the renal level.
Yeah. Renin is 2.2.
So renin is detectable here.
So hypokalemia, what should be the renin?
In hypokalemia, it should be more. No. So will be
Zero.
Zero.
Potassium stimulates. So potassium stimulates renin. So there should be no renin basically. So aldo is also 14. Do you think this is a primary aldo or hyperrenism?
I think it is hypertension.
So what should be done?
Should go for the ultrasound and Doppler.
Okay, CT angio, ultrasound, Doppler, whatever is available. So this was a renal artery stenosis. So not everybody will have a endocrine pattern hypertension. Dr. Sandeep, 16-year-old boy with hypertension, hypokalemia. So again, a big clue which is there. Here, your renin is undetectable. Aldo is 20. What would you think of 16-year-old boy?
So aldo-renin ratio is more than 20 with hypokalemia. So it is primary hypokalemia.
Yes. So you will do.
So CT scan, sir.
Okay. And anything else before CT?
Is genetics will be also required.
Yes. So 16-year-old ask for family history, history of stroke, and you can do a CT also. Family history of stroke was there. CT was normal. Here, before the genetics is done, also you can give them a trial of steroids, and they will improve on that. So they will respond to Dexa or Hydrocort also in that regards. Dr. Nimisha, 8-year-old boy with hypertension, severe hypertension. What you're finding is there is hypokalemic alkalosis, renin low, aldo low. What will you do?
Hopefully, for spironolactone response.
Okay. There is no gonads. Uterus is there. And this looks like a boy, but this is actually cryptorchidism.
This, this is we look for DOC levels.
So what condition are you thinking of?
11 hydro.
So this is more likely to be a 11 hydroxylase deficiency. So of course, all those factors are there, but I think CAH you should think of first before you go to the other one. 26-year-old female with refractory hypertension. Again, potassium is low. ARR is 45. So this is primary. Now what will you do?
You can go for the saline infusion test.
Not required because 45 is too high. So you don't need to do that. Now what will you do?
26. You have to ask for the family history also whether there is a history of stroke or is that. We can go for a trial of dexamethasone and further subsequent to that we can give.
So CT you should definitely do about 20. You do a CT which is normal and AVS. Now this will depend upon whether they want to go for pregnancy. This was the case in which we went for AVS because we didn't want to start aldactone here. Otherwise you can start with aldactone also here. Dr. Vibha, 15-year-old girl with hypertensive crisis with headache and BP is very, very high. Potassium is 2.8. Everything is undetectable. PRA and aldo is undetectable.
Everything is undetectable, so there could be two possibilities.
Yes.
The AME and one other would be littles. We need
Do you think this is too late for little and heavy?
yes, for the little, it is late, but it would be acquired a AME.
Anything else you look on the physical examination in this girl?
We can see for the puberty,
Yes. So that is something which we have to think of. There was no puberty.
the level 17 hydroxy.
Yes.
Presented.
So I think if you talk about overall prevalence, probably compared to littles or 11 beta HSD, the more common will be CAH variants, 17 and 11. So think about those as the first one. So puberty becomes very, very important. So this was the case of 17 hydroxylase. 1-year-old boy with failure to thrive, polyuria, hypertension, potassium is low, pH shows alkalosis, renin aldo undetectable. So what do you think now you start thinking of more of a early onset causes?
So we have two possibilities: congenital 11 beta hydroxy deficiency,
Yeah.
or little.
Yes. So urinary steroid profile or response to aldactone will give you a clue, and this turn out to be AME. Finally, a 2-year-old girl with failure to thrive, hypertension, and you are seeing here that there is hypokalemia, renin is low, aldo is undetectable. We already discussed two differentials.
AME and littles.
Yes, no response to aldactone.
Littles.
So this is more likely to be little. So this is